Welcome to Roadmap to Residency. Hello everyone, I am Aviras. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. Now, we are currently in our neurology module, and this is all about somato, sensory, and motor pathways. So here we have the question. Which of the following best describes the likely location of the lesion affecting the somatosensory pathway? A 42-year-old man presents with numbness and tingling in his right hand and forearm. He also reports difficulty discriminating different textures when touching the objects with his right hand. On examination, there is a loss of light touch and proprioception on the right side of the hand and forearm, but pain and temperature sensations are preserved. Which of the following best describes the likely location of the lesion affecting the somatosensory pathway? Now, if you remember the previous videos, the initial videos of our neurology module, then this question will be easier for you to answer. So we have the options: dorsal root ganglion, medial lemniscus, spinothalamic tract, primary somatosensory cortex, anterolateral system. Now, the patient's symptoms of loss of light, touch, and proprioception with preserved pain and temperature sensations suggest damage to the dorsal column medial lemniscus pathway. This pathway carries sensory information related to fine touch, vibration, and proprioception. Correct answer is B, medial lemniscus. Talking about dorsal root ganglion, the dorsal root ganglion contains cell bodies of sensory neurons but is not a part of the somatosensory pathway that conveys the information about discriminative touch and proprioception. Spinothalamic tract primarily carries pain and temperature sensations, not light touch or proprioception. Since these sensations are preserved in this patient, the lesion is likely in a different pathway. Now, the primary somatosensory cortex, the lesion here would result in contralateral deficits in fine touch and proprioception, but the loss of these sensations in this patient is on the same side as the lesion. Anterolateral system. The anterolateral system primarily carries pain and temperature sensations as mentioned earlier, and these sensations are preserved in the patient, indicating a different pathway is affected. Now, talking about the dorsal column system and spinothalamic tract. Now, these two tracts are one of the most important tracts that is most commonly tested in the sensory pathway. So here we have in the dorsal column system, the fine touch and proprioception sensation from the right side of the body are carried up 2 to 3 segments up, and then these fibers cross. Okay, and sorry, the fine touch and proprioception of the body just goes forward in the same side, okay, in the same side, and then it crosses in the medulla. Okay, it crosses in the medulla, that is a few segments above the level at which it enters the spinal cord, and when it crosses the medulla, then it reaches the midbrain, and consequently it reaches the thalamus and the sensory area of the cerebrum. Now, here you can see that if the lesion is uh, below the medulla, then it will cause the loss of sensations of the same side. But if it is above or at the medulla, then it will cause the loss of sensation of the opposite side. Okay. So if, for example, if there is lesion this side, the lesion will be of this side. Similarly, if the lesion is of this side, the lesion will be of this side. Similarly, talking about the spinothalamic tract. Now, the difference between the DCML and spinothalamic tract is that the spinothalamic tract, it crosses at the same level. Okay, it crosses at the same level of the spinal cord, but the DCML, it crosses at the level of the medulla, and everything else is same. Now, talking about the somatosensory system, it collects the information from the surface of the skin and of the internal cavities, as well as about the position of body parts. We are aware of a part of this information, touch. Kinesthetic and vestibular receptors will be discussed separately. Okay, we have discussed it in the previous videos. The internal receptors will not be treated. Now, the somatosensory system consists of two anatomically and physiologically separate parts: the dorsal column lemniscus medialis pathway, which carries the touch and perceived proprioception. Okay, the proprioception is the sensation of the joints and all when your hands are in space. The anterolateral spinothalamic system, which carries the pain, temperature, and coarse touch. In both the system, the peripheral ending of the primary sensory neuron detects the stimulus. And nerve endings might be surrounded by special structures helping the sensation. Now, this is again the spinothalamic tract. Okay, now this is the DCML. And again, now this is the corticospinal tract. Now this indicates the upper motor neuron and lower motor neuron lesions. Everything that you see is that is are seeing here in red is the upper motor neuron, and here the green is the lower motor neuron. Now, how do you say that something is upper motor neuron or lower motor neuron? Now, the upper motor neuron is continuous from the primary motor cortex. It decossets or does not decossate sometimes, and then it just reaches the spinal cord, and in spinal cord where it terminates, and there is starting of the second order neuron. Okay, now this second order neuron here is the lower motor neuron. Okay, because it is arising from the spinal cord. Now the neuron that arises from the cerebrum or the motor cortex is the upper motor neuron, and the motor neuron that arises from the spinal cord is the lower motor neuron. Okay, now that's why the different pathologies will be the different if there is lesion either in the upper motor neurons or the lower motor neuron. The presentations will be completely different. So talking about one more question, and then we will discuss in brief the upper motor neuron and lower motor neuron lesion sort of types. So which of the following types of touch receptors is most likely affected in this patient, contributing toward loss of discriminative touch? Now, a 25-year-old woman visits her healthcare provider complaining of an unusual symptom. She has difficulty perceiving the texture of objects when touching them with her fingers. She reports no issues with pain or temperature sensation, but notes a distinct lack of tactile discrimination, particularly when handling the objects with her fingertips. The healthcare provider conducts a thorough examination and finds intact reflexes and preserved pain and temperature sensation. However, during the sensory examination, the patient demonstrates a clear inability to distinguish between different textures. Now, the healthcare provider suspects a lesion affecting a specific type of touch receptor. Now, which of the following types of touch receptors is most likely affected in this patient, contributing to a loss of discriminative touch? Free nerve endings, Merkel cells, Misner's corpuscles, Pacinier corpuscles, or Ropeni endings. Now, let's summarize the sensory receptors of the first aid. So there are three nerve endings which carries the A delta C fibers. The A delta is fast. Okay, remember delta waves. Okay, delta speed. A delta fibers are fast, and they are fast because they are the myelinated fibers. C are slow because it is unmyelinated. A delta plane is fast, but a taxi is slow. Mnemonic. All tissues except cartilage and islands contains the free nerve endings, and it carries the sensation like pain and temperature. The Meissner corpuscles are the large myelinated fibers which adapt quickly, and they are present in the glabrous or hairless skin. It carries the sensation like dynamic, fine, light touch, low frequency vibration, or skin indentation. The Pacinier corpuscles are large myelinated fibers which adapt quickly again, and they are present in the deep skin layers, ligaments, and joints. And they carry pressure sense or vibration sense. So remember P for P. Now, Merkel legs are present in the fingertips and superficial skin, and they also carry the pressure and deep static touch. And there are Ruffini corpuscles, and these are also present in the fingertips and joints, and these also carry the sensation from the stretch and joint angle change. Now, talking about our question, the loss of discriminative touch described in this patient, particularly when handling objects with her fingertips, is indicative of a dysfunction in touch receptors specialized for this purpose. Mischner's corpuscles, encapsulated nerve endings found in the dermal papilla of the skin, are crucial for detecting fine touch and texture. Now, their concentration in areas like the fingertips makes them essential for tactile discrimination. So, the correct answer has become Mischner's corpuscles. Free nerve endings primarily mediate pain and temperature sensations and are not specialized for fine touch discrimination. The Merkel cells contribute to touch sensation but are not as specifically associated with fine touch discrimination as Meissner's corpuscle. The Meissner's corpuscles are encapsulated nerve endings, particularly concentrated in areas requiring fine touch discrimination, such as the fingertips. Pacinier corpuscles are responsible for detecting deep pressure and high frequency vibrations. Ruffini endings are again detecting the skin stretch. Now let's talk about one more question about the receptors. Now, which of the following recharge receptors is most likely affected in this patient? A 32-year-old man experiences a sudden decrease in his ability to perceive deep pressure and high frequency vibrations in his left hand. Upon examination, the healthcare provider notes intact light touch, pain, and temperature sensations. The patient is unable to identify the buzzing sensation of a tuning fork applied to his left hand. Now, which of the following touch receptors is most likely affected in this patient? Free nerve endings, Merkel cells, Meissner's corpuscles, Pacinier corpuscles, or Ruffini endings. Now, the symptoms described in the patient, specifically a loss of perception of deep pressure and high frequency vibrations, are indicative of a dysfunction of pacinial corpuscles. Now, these specialized touch receptors are responsible for detecting the rapid change in the pressure, such as vibrations. So, that has become pacinial corpuscle. Since we have discussed everything else in the previous part, let's skip this all and move forward to this question. Now, which of the following best describes the location of the lesion contributing to the observed findings? So maybe this is question of upper motor neuron or lower motor neuron. Let's see. A 55-year-old man presents to the neurology clinic with a sudden onset of weakness and spasticity in his right leg. On examination, there is increased muscle tone, breaks, deep tendon reflexes, and a positive Babinski sign on the right side. The patient also exhibits difficulty with fine motor tasks such as buttoning short with his right hand. MRI of the brain reveals an infarct in the left precentral gyrus. Which of the following best describes the location of the lesion contributing to the observed findings? Lower motor neuron in the spinal cord, upper motor neuron in the precentral gyrus, lower motor neuron in the anterior horn of the spinal cord, and upper motor neuron in the cerebellum, lower motor neuron in the medulla oblongata. Now, the sudden onset of weakness, spasticity, increased muscle tone, breaks deep tendon reflexes, and a positive Babinski sign, along with the MRI findings of an infarct in the left precentral gyrus, are indicative of an upper motor neuron lesion. And the precentral gyrus, also known as the primary motor cortex, is a key reason for the initiation of voluntary motor movements. So, the pathology is there in the upper motor neuron in the precentral gyrus. Now, this is the typical motor pathway, and we will again come back here, but let's summarize this all. So, upper motor neuron disease, pathogenesis, and clinical findings. So, whenever there is a stroke or trauma or brain neoplasm or CNS infection or some myelopathy like spondylosis or spinal cord trauma, it can cause upper motor neuron disease, in which the upper motor neurons are not able to properly signal and control the lower motor neurons and associated skeletal muscle. It can cause decreased transmission of desired muscle contraction signals and decreased upper motor neuron regulation or inhibition of lower motor neuron activity. Now, whenever there is decreased transmission of desired muscle contraction signals, it can cause weakness. And this weakness of upper limb supinator muscles plus spasticity of pronator muscles can cause pronator drift. Okay. Also, whenever there is decreased motor neuron regulation or inhibition of lower motor neuron activity, it can cause increased generalized lower motor neuron stimulation of skeletal muscle, which can cause spasticity. Okay. Now, the thing is that the lower motor neuron activity is actually inhibited or controlled by the upper motor neuron. When the upper motor neuron is gone, the lower motor neuron activity is increased, which can cause spasticity and hyperreflexia. Okay, and the muscle bulk remains normal since muscles are still being used, pertinent negative. Now, the decreased upper motor neuron suppression of reflexive big toe extensor muscle contraction can cause abnormal plantar reflex or Babinski sign. Now, this is the pathogenesis and clinical features that are arising in the upper motor neuron lesion. Again, we have here note on terminology and anatomy. So, upper motor neurons are the first order motor neurons as a part of the CNS. Okay, and the low motor neurons are largely the part of the peripheral nervous system that we have discussed earlier in the picture where I showed you this. Now, the lower motor neuron in the spinal cord affecting the element in the spinal cord typically result in the flaccid paralysis. Our patient have spastic paralysis, reduced muscle tone, and absent deep tendon reflexes. But in human, there is exaggerated deep tendon reflexes, as we have just studied now. The lower motor neuron in the anterior horn of the spinal cord, similar to option A, it will present with features of flaccid paralysis, which is not observed in this case. Also, the UMN in the cerebellum is involved in the motor coordination. So the patient may have motor disorders or the movement disorders. In the element in the medulla oblongata, the lower motor neurons in the medulla oblongata will result in a cranial nerve deficits rather than a symptoms observed in this patient with involvement of precentral gyrus. Now, let's talk about one more question here. So, which of the following best describes the location of the lesion contributing to the observed findings? A 62-year-old man presents to the neurology clinic with a progressive weakness in his right arm. On examination, there is atrophy of the right biceps and triceps muscle. Fasciculations are noted, and there is a diminished right biceps reflex. Now, the patient reports difficulty lifting and holding objects with his right hand. EMG reveals fibrillation potentials and positive sharp waves in the affected muscle. Which of the following best describes the location of the lesion? LMN in the spinal cord, UMN in the precentral gyrus, LMN in the spinal cord, anterior horn, UMN in the cerebellum, and LMN in the medulla oblongata. So the progressive weakness, atrophy, fasciculations, and along with the EMG findings indicate a lower motor neuron lesion. So it is the involvement of LMN in the anterior horn cells is consistent with these findings that is present in the patient. So the answer has become LMN in the anterior horn of the spinal cord. Now again, let's summarize the element here. So the different kind of myopathies, NMJ, neuromuscular junction disease, can cause muscle themselves are unable to respond to intact element signals, which means the lower motor neurons are intact, but there is defect in the muscle itself. But if there is peripheral neuropathy, neurodegenerative disease like ALS, nerve root radiculopathy, then it can cause direct physical damage to the lower motor neurons, which prevent them from conducting signals for muscle contraction. Now, then it can cause the lower motor neuron disease. It is the inability of the lower motor neurons to stimulate effective skeletal muscle contractions. Now, the signals for muscle contraction generated by upper motor neurons cannot be passed into the muscle, so it can cause weakness or flaccid paralysis, fasciculations, and muscle atrophy. Also, since motor and sensory neurons usually run in the same peripheral nerve, damage to the nerve may also cause sensory deficits, which can cause decreased deep tendon reflexes. Thank you for watching. Keep studying hard.